Hi, it's me again. So we're going to go over two talks in this session that begin to address some of the questions that came up at the beginning. I'm going to talk about looking at the big picture of prostate cancer, and then Dr. Onek is going to address in a more comprehensive fashion how to find out what's in your prostate and talk about focal therapy with freezing, two things that Dr. Bostwick alluded to. And I'm a medical oncologist, so my practice, of course, is dominated by people for whom surgery or radiation therapy aren't available or didn't work. So I tend to see the failures. But I do see a sizable number of men who are newly diagnosed and want to have an independent judgment of whether surgery or radiation is needed or whether they are good candidates for watchful waiting. And in the process, I've discovered that many patients and physicians don't really appreciate the magnitude of the problem. Prostate cancer is the most variable cancer that humans get, and it can range from something no more dangerous than acne to a disease that can kill in less than 12 months and everything in between. So this talk is designed to give you an intellectual framework on which to hang information about your disease, and was the map I used to create this meeting. I've tried to identify the best people in the business to address each of the questions involved in determining what you're dealing with. So the key questions here are: what kind of prostate cancer do I have? Where is the cancer? How large is it? And what other diseases do I have that might affect my treatment choice? What kind of prostate cancer, of course, involves things like Gleason grading. Where is the cancer? Is it just in the prostate gland, or is it outside the gland? If it is outside the gland, where is it? What other diseases are very important? Because, of course, prostate cancer occurs in an age group where other diseases are also important. Most men with prostate cancer is equally likely to die of heart disease as they are of prostate cancer. So if you have end-stage heart disease and a Gleason 6, then it hardly makes sense to try and eradicate the cancer since it's not going to affect your life. Okay, I'd like to take each of these questions and try and put some frameworks on this. Well, what kind of prostate cancer do we have? And actually, we ended the last session with a spirited discussion about the fact that some of these cancers are harmless and need no treatment. And the question is, how do you identify that? Is this being identified well in the community? Are people being over or undertreated? As I mentioned further, some will kill in less than a year. I do see men whose PSAs are doubling every 14 days and whose PSAs are in the thousands. And so this can be a very lethal disease. So while there's some people being overtreated, it's equally true that many men are being undertreated. Particularly people with metastatic disease are routinely undertreated in the United States. If you take the incidence figures that Dr. Bostwick was talking about from the autopsy series, you estimate that 30 million men in America will have prostate cancer. Well, 30,000 die in a given year, more or less, and that's less than 0.5%. So really, this is a disease where a vast bulk of the prostate cancer out there is not a threat to the life of a patient, but a small set of disease which is in fact lethal, sometimes rapidly lethal. And where's your disease on this spectrum? What tools do you have to tell where you are? Well, one thing about the spectrum of disease is the pathology. And as Dr. Bostwick said, today the major tool we have, in fact, is the Gleason grade. There are many exciting things coming along from the laboratory that allow us to more fully characterize the tumor. But right now, the Gleason grade is the most commonly used tool, the thing that's available throughout the country. Gleasons 2 through 5 grow slowly and spread slowly or not at all. Gleason 6 is very common. Most are well behaved, but 25% of Gleason 6s are going to spread and kill the patient if they're not adequately treated. And the real challenge is how do you identify that subset of Gleason 6s that are dangerous? Most patients who present to me for watchful waiting are Gleason 6, small Gleason 6. Then, well, what do you do? How do you tell whether this is going to be one of the 25% that are dangerous? So we'll get into some of those issues in the next couple slides. Gleason 7s, most are dangerous, a few are not. 4+3s are worse than 3+4s. In fact, the more pattern 4 you have in your prostate, the more likely you are to have a disease that can threaten your life. Gleason 8 through 10s are life-threatening and need aggressive treatment for the most part. But there are a small percentage of 8, 9s, and 10s that are actually sheep in wolf's clothing. In every large clinic in this country that sees advanced prostate cancer patients will have some 8, 9s, and 10s that are doing very, very well. I just remember one patient I have who, in around 1994, 95, was a Gleason 9 with a bone metastasis. And of course, you can look up the numbers and say, well, that's really a grave situation. But in fact, he's only had to go on chemotherapy this year. So it's been 12 years of avoiding chemotherapy with a bone metastasis. Dr. Crawford will be going through some information about advanced bone disease treated with hormonal therapy, where 15% went into complete remission, and a significant number of those 15% are doing well at greater than 20 years. So again, to emphasize the heterogeneity of this disease. But Gleason grade is a good place to start.